Welcome, guys, to our series of lectures on cardiac pathology. And today we're looking on congenital heart diseases. These are actually disorders of the heart someone is born with. So you find them at birth. So immediately the baby is born, you find these cardiac anomalies present. So usually they are 0.5% of all the births registered in a year. You find that in the total number of births we have in a year, we have 0.5% of all births. Then you realize that most of the causes are multifactorial. So it's not one isolated case or one isolated cause that can be pointed out and say this is the immediate cause of congenital cardiac anomalies. Then usually we have the most risk factors that have been linked or associated with cardiac anomalies. They include the following. These causes are abbreviated as TORCHES, TORCHES, and TO stands for toxoplasma, and then R stands for rubella virus or German measles, and then we have CH, the cytomegalovirus, and then we have the herpes simplex virus. So these are the common causes that have been implicated to most of the congenital cardiac anomalies. Then as we've already said, we can actually classify the congenital cardiac anomalies into three broad categories. The category number one we can actually say is malposition of the heart, all cardiac malpositions. Then the second anomaly that we can talk about is shunts, abnormal communications. Then the third one is obstructions. So under the first one, which is malpositions, we can speak about dextrocardia, where the heart is not normally on its left side of the thoracic cage, rather is on the right side of the thoracic cage. And then we have shunts. Under shunts, we're going to classify them into two. We will have left to right shunt, which is normally known as acyanotic. The patient or the baby who is involved is not having cyanosis, the common sign where we have bluish of the mucous membrane, the tongue, and the nail beds. Usually, cardiac congenital anomalies that are cyanotic, they present with central cyanosis. The difference between central cyanosis and peripheral cyanosis, usually central cyanosis is where the mucous membrane is involved, the tongue, and actually you look at the lips of the individual, you see that this individual is bluish. And usually the central cyanosis can occur with peripheral cyanosis, where the nail bed and other tissues peripherally can look blue. But it's not common to find the peripheral cyanosis presenting first and then having central. It's less common, but it can actually occur. So we've said left to right shunts are cyanotic, and then we have right to left shunts, where we have a communication between oxygenated blood from the right side to the left side. There's a mix of blood. Then the blood from the right side that is mixing to the right side is going to mix to it and then supply to the other parts of the body, and then it causes cyanosis. So under left to right shunts as cyanotic disorders, we're going to have conditions such as patent ductus arteriosus. We're going to have another disorder such as even dextrocardia itself is a cyanotic heart disease, but we also have the ventricular septal disorder, where we have the septum between the ventricles is actually having an communication. So we can also have atrioseptal disorder, where we have communication between the atriums. And then we can actually have mostly the three common. So among the three that we've spoken about, the VSD is actually the largest, is the most common contributor of all the cardiac congenital anomalies. It contributes to almost 20 to 30% of all the cyanotic and all the congenital cardiac disorders. We can speak about the cyanotic, where we have the blood from the right atrium mixing with the right side of the heart is actually mixing with blood on the left side of the heart, and thus it's pumped to the other parts of the body. For example, we can have something called tetralogy of Fallot. Tetra means 4. So we have 4 anomalies in one. In this condition, we have a VSD, a VSD where we have ventroseptal defect. We have a communication between the right ventricle and the left ventricle, and then we have actually overriding of aorta over the sinus, over the foramina, over the abnormal VSD. So it overrides the VSD, and then actually the smooth part of the aorta, where we have the outlet part of it, is now on the right side, on the right ventricle, or the right sided part of the heart. And then we have another disorder in the tetralogy of Fallot is pulmonary stenosis and hypertrophy of the atrium. So we have 4 conditions. One, there is ventricle the interventricular septal defect, where there is a communication between the ventricles, and then we have overriding of aorta. What is happening here? You have the aorta, actually the smooth part of it that developed from the bulbous cordis, it has overrid the defect and is now originating from the right ventricle. Then we have a stenosed pulmonary artery. Because of this, there is hypertrophy and hyperplasia of the right ventricle. 4 conditions in the tetralogy of Fallot. Then other cyanotic conditions is common atrium. Sometimes you don't completely form the septal, the cushions that we've already spoken in our previous lecture. You're going to find it there. So we have common atrium. We also have the persistent truncus arteriosus. You realize that on the cephalic end, in the cardiac loop, in embryology, in our previous lecture, you're going to find that we have cranially, we have truncus arteriosus. It's going to be partitioned later to give us pulmonary trunk and the ascending aorta. What's going to happen when we haven't actually had partitioning of these trunk or truncus arteriosus, you're going to have a common truncus arteriosus, persistent truncus arteriosus, where the blood from the left ventricle and the right ventricle are going to mix up in this chamber that should have normally partitioned. That's the second commonest part of or cause of cyanotic heart disorders. Another common cause of cyanotic disorder is when we have a syndrome in which the VSD, which usually is cyanotic, later can develop to, which is usually a cyanotic, can actually develop to cyanotic. Under what conditions? When the left ventricle consistently pumps its blood, then the high pressure zone of the left side of the heart is overwhelming and then pumps blood to the right side via the ventricular septal defect. Later we're going to experience that you're going to have an hypertrophic and hyperplastic right ventricle, which later is going to actually develop an adaptation that gives it the strength to accumulate pressure that is going to overrule or surpass that or the pressure from the left ventricle. Thus, what we're going to see is a condition in which there is a change from a cyanotic heart condition, left to right shunt, to actually a right to left shunt. So that's another common thing. Under the third classification that we've spoken about is obstructions of the heart. You can speak about aortic stenosis, mitral stenosis. You can speak about pulmonary stenosis. You can speak about coarctation of aorta. Thank you so much, guys. We'll meet on the next. If you have a question, drop on the comment, subscribe.